I've been CMO at the Polyclinic for the last 10 years, and I was on board when Vitel came on board, and in fact was part of the process as we looked at solutions for population health management. In our structure, I'm part of the executive team, so I was the executive sponsor for population health since it's a clinical endeavor, and I oversee the clinical endeavors of the clinic. We had implemented an electronic health record, and our electronic health record is shared with a hospital system and with a number of other clinics and providers. So it's a common electronic health record, and reporting out of a common electronic health record that's so big was very complicated. So what we were looking to do is we were looking to make reporting of what is a very good clinical data repository. We were looking to make reporting out of that streamlined and customized to the needs of the Polyclinic to meet both our business needs and our clinical needs, and that's what we were looking for was sort of a sit-on-top solution, to take that. We also have had a data warehouse in existence for almost 10 years that has a lot of financial data, and again, like that, we were looking at some point in the future, hoping to be able to integrate the data and to come up with a combined clinical information, business information platform that we could use, not only around the clinical care in terms of the population health management, but also what's becoming increasingly more important around the cost and resource management of delivering health care. The Vitel solution has addressed the biggest issue, which is getting our clinical data out of, an electronic health record in a reporting format where we can then take the next step and do something about it. So I think that that's really the big issue. The big issue was that we had this giant clinical data repository, in the form of an electronic health record, and it was doing what it was designed to do, which was to document episodes, but it really wasn't connecting all of the dots in a way that made sense for taking care of patients, particularly in an era where you have to see a lot of patients, you have to take care of them quickly, and you don't have a chance really to do it in the way physicians might have done it 20 years ago, which is to leisurely thumb through a paper record and look for all the little things that they should be addressing. So what we really wanted to do is to streamline all of that and really have the patient and the physician have what I call a high value visit. So in a high value visit, you don't spend time looking for data. In a high value visit, you develop that patient relationship. You use those chances to teach and engage patients, and hopefully get them motivated like that to improve their health. So Verisk allows us to accumulate all the claims data on our population, and one of the advantages that we had when we went with Verisk was that it was known in the industry with the health plans. So getting those data sharing agreements that had been very difficult to do for us in the past became much easier. And in terms of what would happen with an ultimate integration of both the data from Verisk and the data from Vitel, is that we would begin to be able to demonstrate different value propositions. For instance, how much it costs to bring a diabetic patient into control, for instance, would be a good example of that, or the total cost of a knee replacement, beginning from when the diagnosis is made that somebody needs a knee replacement on to the point in time when they went back to work. What it allows provider groups to do is to demonstrate their value, to demonstrate their outcomes and the resources that they use to get to those outcomes and the costs. And in an accountable care environment, providers that can demonstrate good outcomes and reasonable costs to achieve those outcomes will be at an advantage in the market. Approximately half of our primary care attributed patients are in some form of a risk-based contract, ranging anywhere from capitation with Medicare Advantage to shared savings programs, both with Medicare and with commercial populations. I think that having FITEL basically being the ability to look for care gaps and the ability to begin to start to coordinate care and to look at high intensity patients gives us a level of confidence that we wouldn't have if we didn't have that ability. Two things that you're going to have to be able to do is you're going to have to be able to manage risk, but probably even more important than managing risk is you're going to have to be able to drive down cost, and having the ability to make sure that we start to look at our populations and make sure that they get exactly the care that they need when they need it, that it's not too much, which drives up cost, that it doesn't come too late, which drives up cost, are all important considerations. I think that the future of healthcare is really going to be around the idea of demonstrating value, and it's better from a provider point of view to be able to demonstrate the value to a potential payer than have the payer come in and make their own judgments about what value you bring. I would say that the movement from volume to value it's necessary but not sufficient that you have the appropriate data and information systems to do it like that. There's a lot of other elements that go from actually moving from volume to value, and the trickiest part really at this particular point is that we are in a volume-based reimbursement schema, and that's unlikely to switch over to value quickly. It's an evolutionary piece. So I think that the important piece about keeping your eye on moving towards value can't happen at the expense of not paying any attention to volume. So a good volume strategy is providing high value services and filling high value care gaps with existing patient populations.